Okay, we are recording. And put us backward. Okay. So let's start with this one. Shane, you want to start us off? What do you see?
Yeah, so, I mean, there's a few newts in the horn. There's like
So give me a differential for newts in the horn since you're starting there.
So you have psoriasis, that's kind of out. Syphilis would probably be up there. You have the reedy are kind of slender. And,
yeah. So newts in the horn, P-tick, psoriasis, impetigo, candida, sebderm, syphilis. This one has a lot of dermal inflammation. You know, so dense it's kind of hard to make out if it's interstitial or not. If you look higher, there's no shortage of plasma cells here. Plasma cells only present in about 2/3 of cases of syphilis. Mixes of patterns, so spongiotic plus interface plus granulomatous, funny combinations of inflammatory. Always think of drug viral syphilis, and this particular one was syphilis. You're going to have to confirm it with testing for spirochete or serology. Remember that none of those are 100%, so you often have to keep high index of suspicion.
Any way to tell that? That was like a shaker, or less likely secondary syphilis on that, or what? Or could that have been any?
Oh, in terms of the stage,
yeah.
Probably not chancre because there's no ulcer,
Okay.
right? So, and it's not granulomatous, so probably not tertiary. So it's that broad range of secondary syphilis, which is the vast majority of what shows up in skin. So, if you run a VD clinic, which I did for about 15 years, then you're going to see chancres, but the most of what derms see in practice is secondary.
So it's like biopsy. The cornea looks vascular. Looks like there's maybe some perivascular inflammation.
Yeah. So is there anything very dramatic here?
No, not really.
Really not, right? This is syphilis. It is the great imitator. It has a huge spectrum of changes clinically, and if it's going to have a huge spectrum clinically, then it's going to have a huge spectrum histologically, right? So when we did our syphilis study in New York, there were cases like this, and I called the pathologist involved and said, what prompted you even to get the stain on this? And they said, well, this one, the clinician thought it was syphilis. Right? So there are cases where you back into it just because the clinician thought, but it tells you the spectrum of what, not all syphilis has icicle-like acanthosis and interface and newts in the horn. It can be very nondescript. Now, if you look at it objectively, there's a little bit of spongiosis. There's also a little bit of interface. So it's got that kind of odd mix where you might think of drug viral syphilis. But it can be very, very nonspecific. So you have to think of it. Generalized lymphadenopathy in any patient. One of the important things in the differential is syphilis. Patients who just present with generalized lymphadenopathy. Generalized lymphadenopathy with multiple organ failure. So they have unexplained hepatitis, renal disease, lymphadenopathy, all of those things, weird combinations of things. Think syphilis. Okay, how about this one?
So there's some sort of pretty superficial and deep dermal inflammation.
Okay,
Um,
and what type of inflammation?
From here, it looks maybe histiocytic.
So you certainly have areas where you've got a sea of pink or amphiphilic cytoplasm with nuclei and no connective tissue in between. So that's a granuloma, right? So you definitely have granulomatous, and then you have little black round things, so that's lymphoid, right? So you have granulomatous and lymphoid inflammation. And so what's your differential? First
So,
off, any pattern to the granulomas?
yeah,
Are they particularly vertical or horizontal or anything like that?
pretty horizontal.
Pretty horizontal to the surface. So in the deep dermis, they run horizontal to the dermis. Is that a clue to anything?
Yeah, so it's like tuberculosis leprosy.
Yeah. So leprosy, the granulomas follow neurovascular bundle as well as erector pili. That means in the deep dermis, they tend to run parallel to the surface in the deep dermis. And then you've got the lymphs. You know, when you have this many lymphs, it's most likely a reactional state, right? Leprosy often gets biopsied when it's in reaction. So a reversal reaction, downgrading reaction, ENL. Erythema nodosum leprosum is leukocytoclastic vasculitis that occurs by immune complexes that form locally where the organisms are. So it's not circulating immune complex, it's local immune complex deposition in sites of disease. And it's going to be neutrophilic like any other immune complex disease. It's LCV basically, whereas the downgrading and reversal reactions are lymphoid.
How do those work again, Doctor? The downgrading reversal. Is there?
So the reversal reaction is where you're regaining immunity. Leprosy survives in your body because it evades your immune system. When you regain immunity, you're now sending lymphocytes in to chew up everything where the organism is. Unfortunately, it chews up your nerves in the process. So much of the disability that patients have, the acute pain, the acute loss of function, relates to reactional state. So it's easy to start people on dapsone and rifampin, but that's when they often have horrible reactions with pain, deformity, loss of nerve function, and that's when you have to, so the real art of treating leprosy is treating the reactional states that occur. And then downgrading is a similar reaction that happens when you're going the other way, and so it makes no sense.
Yeah, I was confused.
It's kind of counterintuitive how that can look similar, but it is. So, my wife has an easier time with it. She's Catholic. It's a mystery, so that she just accepts that. Whereas I'm brought up Lutheran. I'm forever looking for the explanation for why. And I can't figure that one out. So she's better off. It's a mystery. And then Lucio's is in the presence of what's probably a different organism. Instead of being M. leprae, it's M. lepromatosis that gives you diffuse lepromatous leprosy, a massive load of organisms within the vessels. You get thrombus and intravascular inflammation so that it looks histologically a lot like Berger's disease, with inflamed thrombi in the vessels. But with that, you have a huge load of organisms. So if you do an acid fast stain, it's loaded with organisms there. And it shows up, what would you expect if you have thrombi in large vessels, especially arterioles? What's it going to look like clinically? Stellate. So it's retiform purpura and necrosis. Exactly. And, you will see it occasionally in practice. I've seen it twice in patients who are, admitted to the hospital. They have these, bizarre ulcers that everyone's focusing on, and no one's really paying attention to the fact that their face is all puffed up. They have no eyebrows. Their ears are lumpy. Okay.
Pretty prominent acanthosis.
Yeah, so very prominent acanthosis.
And then in the dermis, we have some histiocytes.
Yeah, so granuloma surrounded by lymphs. So how do you describe a granuloma with no lymphs around it?
Naked granuloma.
Yeah, naked granuloma or sarcoidal granuloma, whereas a granuloma surrounded by lymphs called tuberculoid.
Tuberculoid.
So a tuberculoid granuloma. So early, with bad microscopes, they started to differentiate how sarcoid looked different from tuberculosis. Sarcoid, the granulomas tended to be naked, no lymphs. Tuberculosis, lots of round cells, many of which are actually monocytes and mixed with lymphocytes. They're the cells that become the granuloma eventually. And so basically you've got a granulomatous dermatitis here, right? So what's your differential for a granulomatous dermatitis?
Well, for this chapter, there's tuberculoid, leprosy.
So leprosy, what else?
TB itself.
Yeah. So lupus vulgaris, which is cutaneous TB. Scrofula, if you have draining sinus tract out of a node in the neck. So scrofula is just a suppurative lymphadenitis on the neck that starts to drain. Periorificial tuberculosis, where you have around your mouth, commonly anus, genitalia, you have draining sinus tracts. Those are all manifestations of TB. Syphilis can look like this. And then you've got your...
Crohn's. Like Crohn's.
So cutaneous Crohn's absolutely can look like that. Zirconium and beryllium granulomas can look like that. They tend to be a little more sarcoidal than tuberculoid, so fewer round cells. But then you've got your kind of the holy trinity of infections that appear in skin as granulomas are fungal, AFB, syphilis. So, or I guess they would be the unholy trinity. So fungal AFB syphilis. So anytime you have indurated granulomatous lesions, when you see a grand rounds, chronic skin lesions that look granulomatous, and when you get to infectious, you have to say AFB, most of which, that includes leprosy and TB, but includes all the atypical mycobacteria, right? Fungal. And then Louis can do any pattern. Okay, very good. So let's do... Where is our tissue? Right there. There's a smudge right on top of it. That's not very nice. Let's see if we can get it a little better. There we go.
So I see some, I think, lymphs and histiocytes in there. In the dermis, there's some lymphs on a pillow in the epidermis.
Okay, so some epidermotropism
Right.
with little white halo around it, similar to what you could get in MF,
Mhm.
right?
And then there's a little bit of, I'm not sure what's in the corneum, schmutz of some sort.
Oh, that's formalin pigment.
Oh, never mind. This might be another granulomatous type.
So it could be granulomatous again. You have an interstitial, sort of busy dermis down here. You have a little bit of interface, especially on the follicle. You got a little bit of spongiosis there. You even have some plasma cells in this one, and this is syphilis again. So you have to keep high index of suspicion. Let's see. Okay, David.
So, a lot going on here. It's almost like lobulated. It's almost like really vascular appearing,
Yeah, so you said lobulated vascular. What does that make you think of?
like a pyogenic granuloma.
Like a pyogenic granuloma. And what's on the surface of this eroded PG? What are all of these big purple circles?
Could be bacterial colonies.
Yeah, what
Staph.
bacteria forms large clusters?
Staph.
Right.
Bacterial, like I said.
So Botrytis is if it's draining out of sinus tract. This is what something that's impetiginized crust looks like. So an impetiginized crust just has these huge staphylococcal colonies. If you have similar colonies coming out of a sinus tract, that's botryomycosis. Okay, so staph forms huge grape-like clusters of.
So that's granulation tissue there?
No, there's a PG.
Just-
It just PGs become impetiginized dime a dozen.
So, looks like you've got kind of an interstitial infiltrate.
What kind of cells?
Looks like plasma cells.
Plasma cells. So an infiltrate with lots of plasma cells. What does that mean?
So, I mean, if you have a little interface, you could think of syphilis.
So with interface, especially in this chapter, you'd think of syphilis. What other things recruit plasma cells?
Rhinoscleroma does. but
So
it's more
rhinoscleroma
diffuse.
does,
Like
and
Russell
it's
bar.
on the rhinoscleroma tends to occur on the
Uh,
rhino, right, on the
on
nose.
The nose, right.
And there are places where you tend to recruit plasma cells anyway, right? So face,
Macarena.
occiput, exactly. Mucous membranes, neck, axilla, breasts, flexures, umbilicus, anogenital, which we don't do, and chins tend to be places that recruit plasma cells anyway. So anogenital is part of that. So we make a big deal of plasma cells in chancres. A traumatic zipper cut has lots of plasma cells because it's just genital skin that's inflamed, right? So chancroid looks a lot like chancre histologically because it's a genital ulcer, and anogenital skin, when it gets inflamed, is going to have lots of plasma cells. So, but syphilis takes its plasma cells with it from the mucous membrane wherever it goes. KS, early KS has plasma cells. And so one of the ways that residents said they remember that is it's trying to tell you I was acquired on a mucous membrane and now I'm taking my plasma cells with me. So a number of the STDs take their plasma cells with them from the mucous membrane when they go elsewhere. So that can help you sometimes with those. So it could be site, it could be innate to the condition. Certainly syphilis does it. Another one that's famous for doing it is leishmaniasis. Leishmaniasis often has a big plasma cell infiltrate. Okay, let's see what else we have to do here.
All right, pretty thin shave. Pretty stratum corneum's pretty dense.
Yep.
So there's a little bit of spongiosis. A bit of
Little papillodermal fibrosis, and then looks like melanocytic hyperplasia. A lot of pigment in the corneum.
like
I suspect this is
granular
melanoma in
character.
situ. It's completely unlabeled and sitting in this box. It's really good at where it belongs.
I kind of get that.
Well done. Okay.
Infectious.
Okay. Let's. How about if you do this one instead?
All right.
But remember that for real life and for board exams, you're not going to know what chapter it came from. So at some point, you know, especially after your first year, you have to start getting out of the chapter.
Looks like maybe a normal stratum corneum with faced reedy ridges. Seems to be some holes in the superficial dermis. Some inflammation down deep. Looks like lymphohistiocytic. Lots of kind of gray, blue debris in there. Some kind of organism.
So see that thing right there?
That's globi.
And those are what globi look like, exactly. So they're amphiphilic, kind of strandy, granular looking, and you have to recognize them. So that's what globi look like, and so that was Lepromatous disease.
Looks like you have a little bit of interface dermatitis and then some granulomatous kind of down deep.
Interface and granulomatous, that's a weird combination.
Yeah. I mean, syphilis would probably be at the top of my list right now.
And what else?
I mean, in the chapter, you got leprosy.
Yeah, but how about outside the chapter?
Atypical mycobacterium fungal.
For the granulomatous part, for interface plus granulomatous?
Oh, drug viral syphilis.
Yeah, exactly. So drug and Louis are probably at the top. This one happens to have lots of plasma cells, has interstitial busy dermis, all of which are syphilis features, which is what that one was. Let's see what else we have.
I think we found the missing syphilis box. It's just mislabeled.
No, there's fortunately there's syphilis in the bacterial boxes, but there are boxes and boxes of syphilis that are somewhere.
Like handouts. Server. That's a central ulcer there.
Yes.
Pretty busy dermis. Very stain.
Yes, you have sort of a lot of interstitial inflammation.
There's like some elongation of some of the reed. I mean, I'm thinking like a chancre maybe.
Yeah, chancre tends to have a lot more granulation tissue and be broader, and is more likely to be mucosa.
I see.
This has a bundled dermis like skin and lots of adnexal structures. But something suppurative with some granuloma surrounding it, so forming kind of a stellate abscess.
Maybe like AFB and TB.
So atypical mycobacteria certainly can do that. TB can do that. What else can give you stellate abscess? It's
Cat scratch, tularemia.
yeah. So that's the clats.
Okay.
It's good to have little mnemonics. So cat scratch, LGV, atypical mycobacteria, tularemia, sporo. This particular one was cat scratch, but you just need to have, whether that's in a lymph node or in skin, it's good to have a little differential you can go through. They're in the back of the book too. There's a little table of mnemonics in the back of the book that helps with all of that.
Looks like congenital nevus.
Looks like a congenital nevus. First off, where do you think you are?
Oh, that's scalp or breast.
So there are apocrine glands. So lots of apocrine glands. What kind of areas could that put
Maybe
you?
axilla.
So maybe axilla and anogenital also
Okay.
can be apocrine areas. Ear canal is another one that has lots of apocrine. That's what cerumen is, modified apocrine. And what else do you have? What kind of cells?
Plasma cells.
Sheets and sheets of
Yeah.
plasma cells.
They're not melanocytes.
And but plasma cells and melanocytes are both gray, right? So that's why at scan you knew they weren't lymphs because they were gray, right? And it was patchy, like a congenital nevus would be. But in this case, all plasma cells. So you're on an apocrine gland-bearing area. You have sheets of plasma cells.
Yeah. I mean, syphilis.
And what do you think this one would have looked like clinically?
Almost like an SK or a condyloma.
Yeah. So is there any kind of condylomatous thing that syphilis produces in anogenital,
Yeah, like
condyloma lata, which condyloma acuminata tend to be bumpy, cerebriform. Condyloma lata means flat, right? So flatter, and they can be flat. They can also be gyrate. So you can have gyrate lesions, periorificial, or very typical for sarcoid and syphilis. Okay, and then there's another one that happens to be an immunostain, just so you can see what spirochetes look like. So they tend to be in the lower third, and they tend to be vertically oriented. So lower third of the epidermis, vertically oriented. Of course, that's exactly where melanocyte dendrites are, right? So with an immunostain, easy to tell them apart. With a silver stain, the difference again is melanocyte dendrites are black and granular. Spirochetes are gray and not granular. Let's see, what else we got here? Just another special stain. This is a patient with lepromatous leprosy. And you can see what the globi look like when you stain them. So those little circles become lots of rods when you stain it with a fight. So you wouldn't do a Zeal Nielsen. You do a fight or Kenyan stain, or you can do, for anything acid fast, you can do auramine rhodamine fluorescent stain. That's probably your most sensitive for anything acid fast to include leprosy. And TB. So auramine rhodamine hits everything. Okay, what do you see here?
This slide looks like a cancer cyst, epidermis, interstitial. Looks like
And
yeah.
what area of the body, given all these little smooth muscle bundles?
It's from genital skin.
Yeah, so anogenital skin has lots of smooth muscle, head and neck skin has lots of little bundles of striated muscle. This is smooth muscle, so that's anogenital.
So this slide is the first I consider of the syphilis.
And that's what it is. So it can be acanthosis or effacement, often combinations of spongiosis or interface. This one's mainly just interface. The busy interstitial pattern in the dermis is very characteristic. It can occur anywhere on the body, but you often have gyrate or petaloid lesions in anogenital areas. So that's a common clue. Let's see. Let's get.
So, looks like we have a lot of inflammation around fat and then blood vessels. They look like lymphocytes.
So lots of limbs, and they're surrounding what?
So looks like they're making granuloma.
Yeah, so limbs surrounding granuloma. So is this more sarcoidal or more tuberculoid?
Tuberculoid.
So this is tuberculoid granuloma.
Mm-hmm.
And what things can cause tuberculoid granulomas?
Like tuberculosis.
Obviously TB, that's where it gets its name. What else?
Tuberculoid leprosy.
Tuberculoid leprosy absolutely can. That's why it's called tuberculoid leprosy. Just so what's the unholy trinity of granulomatous
Like
disease in the
AFB,
skin?
Fungal.
AFB, fungal syphilis.
Yeah.
So if you just do those broad categories, AFB includes leprosy, includes TB, includes all the what they now call MOT, mycobacteria other than TB. So it includes all of those, and then fungal, deep fungal, and syphilis. So AFB, deep fungal syphilis is sort of your knee-jerk, unholy trinity of infectious granulomatous disease in skin.
There's some sort of inflammation. It's like newts in the.
Yeah. So you have spongiosis and you have newts in the horn. You also have Langerhans cell granuloma that just goes with the spongiosis, right? So you got spongiotic dermatitis and then newts in the horn. You got some EOs in the tissue.
So the differential newts in the horn is P ticks.
Which
so
are?
it was probably not psoriasis.
Well, can psoriasis be spongiotic?
Oh yeah.
Yeah. Anything other than plaque psoriasis, right? All the other forms can. So impetigo could just be impetigonized, giving rise to the newts. Candida, sebderm, especially if it's parafollicular, and syphilis, would definitely be in your differential. The other thing that gives you newts in the horn, together with spongiosis, toxic shock syndrome does that, and scarlatina does it. So scarlet fever is streptococcal and is basically streptococcal toxic shock with the whole spectrum of disease. And then what we call toxic shock syndrome is staphylococcal toxic shock. So toxic shock syndrome was first described with strep back in the days of rheumatic fever, when people would get toxins that would make them shocky, etc. Then came back with Rely tampons as a staphylococcal induced disease. And then since then we've had several horrible epidemics of toxic strep again. That's what Jim Henson died of, a strep throat with toxin and just multi-organ shutdown. And they all give you toxin-induced erythroderma, shock, multi-organ failure. And it can be staph or it can be strep in origin. And when you biopsy the erythroderma, you have spongiosis and newts. So it's one of those that in the right clinical context can be toxin-induced erythroderma.
The EOs.
And the EOs are variable. They've been described. They can happen in there. So let's see.
Looks like we have, I'm not sure if that's like central necrosis.
So central necrosis, any kind of inflammatory cell around the central necrosis?
Yeah, just I feel like there is, so it makes me think of like TB.
So caseous necrosis with surrounding granuloma would be classic for TB, but it usually does not have neutrophilic debris. So does this have neutrophilic debris or no neutrophilic debris?
Yes.
Yeah, neutrophilic debris is present. You got it right, even though it was the first choice. Good for you. About the only time you see that in tuberculosis, you don't see it in granulomatous disease like miliary TB. You're not going to see neutrophil, but you will see it in scrofula. You will see it in the periorificial TB. So those you will see neutrophils. So a neutrophilic abscess with surrounding granuloma, give me a differential.
I think Wegner's can.
So Wegener's on the vasculitic side absolutely can, and on the infectious side, and Wegener's we're supposed to call angiitis with granulomatosis, right?
Sure, TB's. This doesn't have this appearance, I don't think so.
Yeah, so this one isn't particularly stellate, but it still gives you a similar differential of cat scratch, LGB, atypical mycobacteria, tularemia, sporo. You can also do a broader AFB fungal syphilis type differential, which will cover most of it. That misses cat scratch and tularemia that could produce this pattern, and LGV, that's bacterial, or I guess the organism is closer to a bacterium than anything else. So, just like trachoma, they're closely related to rickettsia.
epidermis looks okay, but a little bit more deep in the dermis. There's inflammation.
Morning.
So it looks pretty granulomatous. There might be some newts in there as well.
Okay, so you're describing something suppurative and granulomatous.
Correct.
Broad differential for suppurative plus granulomatous?
As we said, like the cat scratch, LGV, tularemia, sporo, you do fungal.
That's especially if it's forming a stellate abscess. And
Okay.
then, sort of broad for suppurative plus granulomatous in skin. Unholy trinity of...
Oh. The AFB, syphilis, and then fungal.
So the whole family of acid fast, deep fungi. So you go on a bug hunt for deep fungi. You may want to stain it for syphilis, check serology, and this particular one had acid fast organisms and was a rapid grower for 2 of them. But you can get as far as a differential. That's about it.
The shade biopsy, it's got that busy dermis kind of look.
So busy dermis plus interface.
Looks like could be syphilis.
Could be syphilis, which is what it was. And this now is a stain that looks like a PAS. Doesn't look like an acid fast stain. And let's see if we see. It's mainly neutrophil, not seeing organism. And let's see if we can find them somewhere else. Well, they're not jumping out at me around necrotic vessels. Abscess and where there's transepidermal elimination, that's a good place to look for organisms. See, in there, we're starting to get them. So it looks like some yeast in there. So, again, not the right chapter, but right differential. Okay. Okay, whose turn are we?
So, looks like maybe mainly an interstitial infiltrate.
So mainly interstitial.
Kind of, it's a collagen kind of thin.
Probably some edema.
Okay. That's nudes.
Yeah, so you definitely have neutrophilic inflammation. There's some acanthosis, suggesting it's, not an acute process, but a little more chronic process.
Sure.
And basically, you've got interstitial neutrophils almost to the point of abscess formation, and then you have, see that multinucleated cell? So you're basically looking at a combination of suppurative and granulomatous dermatitis.
AFB fungal syphilis.
AFB fungal syphilis would be your, on the infectious side, the things that you'd want to look for, and this one grew an atypical mycobacterium. Let's see.
Looks like lots of plasma cells.
And how about your epidermis?
So it's acanthotic. It's kind of papillomatous, maybe.
So acanthotic, mild acanthosis, or to the point of pseudoepitheliomatous hyperplasia?
To the point of pseudoepitheliomatous hyperplasia.
And then, what would you
A
call
little
this
bit of,
big?
neutrophilic.
So what's?
neutrophils in
Do you
it.
have a differential for PEH with pus?
Sure. Halogenoderma, chronomycosis, blastomycosis, LGV, and Pemphigus vegetatis.
Yes. So PEH with pus. Here come big green leafy veggies. So some of those are toxic ingestions like halogenoderma. Some of them are immunobullous. Some of them are infectious. So it's nice to have a mnemonic that helps you remember it. You go on a bug hunt, you do stains, and this particular one grew M. marinum. Sometimes the clinical presentation can help too. M. marinum tends to be lymphangitic. Other things tend to be ulceroglandular. So ulceroglandular is you have a sore and a swollen lymph node, nothing in between. Lymphangitic, you have nodules along the lymphatic vessel, right? So your lymphangitic things include sporotrichosis, M. marinum, leishmaniasis, nocardia. Those are things that are lymphangitic, whereas things like TB and cat scratch skip the vessel and go right to node. So lymphangitic versus ulceronodular can help divide your differential. And there's a nice table in the book that gives you your lymphangitic organisms versus the ulceroglandular organisms, which is good to know. Some of them are germ warfare organisms, things like glanders, plague, milioidosis, all of which can be weaponized, and dermatologists are the ones likely to recognize those uncommon infections because you notice something that's ulceroglandular. Okay, what's my differential for ulceroglandular? And you run down that differential. So we were the ones who called initial attention to a number of recent outbreaks to include anthrax and other things like that were derms because they had learned it in residency. And you see the things in real life occasionally, and you see them as public health issues occasionally. Okay.
Looks like there's some pigment incontinence.
And pigment
I'd say-
incontinence suggests what?
That there's damage to the interface.
Yeah,
or
so
basal layer.
suggests that there was probably a prior interface dermatitis, right? And then
Mhm.
what kind of inflammatory cell?
There's some plasma cells in there, some
And
lymphocytes.
how about your dermis?
Pretty busy.
So you got a busy dermis, plasma cells, pigment incontinence suggesting interface.
I think syphilis would be at the top of your list.
Syphilis would be at the top of your list.
And then can't you get lymphs with like extra cytoplasm? Have you been?
That is,
Can you find some of those
endothelial swelling and lymphs with lots of cytoplasm are very typical things which have not been prominent in the examples we've seen, but they can be very prominent and sometimes the only thing you see.
Yeah, internal infiltrate here.
Thank you for pointing those things out because they're important. Okay, so dermal infiltrate,
Yeah.
and how would you characterize it?
Maybe.
Yeah.
Granulomatous.
So granulomatous. So granulomas are histiocytes packed together with no intervening connective tissue.
Kind of horizontally oriented.
Horizontally oriented,
Leprosy.
and then this also has lots of circles, and you look, is there stuff in the circles? And if there's stuff in the circles, you want to stain it because there's a globi, and this is leprosy. So you have epidermal necrosis with slough and a bulla. So this is something that would have been bullous clinically. Lots of inflammation. So it would have been an inflammatory base with a bulla. Goes all the way down into the sub-Q.
I almost wonder about something vascular tropic.
Yeah, there's vascular necrosis, so you'd worry about things like fusariosis.
Mucor.
Absolutely. So any of the vascular tropic fungal organisms, you'd worry about bacterial infection with suppurative. There's extensive sweat gland necrosis. Right, so that's the sort of thing you can see in coma, blister, but this is awfully inflammatory for a coma blister, right? This is neutrophils within the sub-Q. So what's your differential for a neutrophilic paniculitis?
Well, I feel like it could be pretty broad and more than just infectious.
So infectious, of course, is number one. But what else?
Can alpha-1 antitrypsin also
Alpha-1
be?
antitrypsin is big one that you're not supposed to forget because of the risks to the patient, and connective tissue, exactly. So connective tissue paniculitis can do it as well. So you have to screen for connective tissue, screen for alpha-1 antitrypsin. You want to culture it, and you want to culture it routine AFB fungal, and in this case, there's some history. Patient has cirrhosis and had a recent trip to the coast. What are you thinking about someone cirrhotic who has likes mollusks and recently went to the coast? So that's Vibrio vulnificus, marine Vibrio, where you tend to become septic if you have cirrhotic liver disease. So most of the people who die eating oysters have underlying liver disease, and are prone to the sepsis. Okay, let's see what else we got here. Okay, so this is, the stain is blue and the hair fiber is red. That tells you it's a fight. That's what a fight stain looks like. And so, someone was on a bug hunt for AFB with this one. And then you'd have to look to see if they found it. It's certainly not in lots of globi. In fact, it's not a very inflammatory biopsy. It's more papillodermal edema in that one. The history is that this is leprosy. My guess is this is reactional state with the limbs, and I don't see a lot of granuloma. This is probably not a very high yield area. Remember, if you're looking for the organisms, especially in tuberculoid disease, you have a higher yield with PCR, but in order for PCR to work, it has to be an alcohol, not formalin. So if you're thinking PCR for an organism, alcohol, not formalin. Let's see, what else we got to do? We're probably at a stopping point here, and we got to get downstairs because we are going to be, for the next couple of weeks, we're going to be playing catch up after the storm. And our policy is if patients wander in saying, "Can you see me?" the answer is pretty much yes, because if it's bad enough that they're coming out in this weather to get seen, they probably need to be seen. Okay, thanks everyone.
Ready to do that?
Yeah.
Yeah, so I'm working on it.